Hi, welcome to my presentation on the pharmacological management of constipation in the medical ICU. My name is Anita Matthew. I am a PGY1 pharmacy resident at the Central Iowa VA. This lightning presentation was developed to improve patient care. The contents of this presentation represents my views only and are based on the references at the end of this presentation. They do not represent the views of the Department of Veterans Affairs or the United States government. Several therapeutic modalities are available to the intensive care provider for treating constipation. However, due to the lack of published literature, questions still exist regarding the optimal use of laxatives for medical ICU patients. I hope to highlight some of the nuances among the laxative options with this presentation. Constipation has been defined as the lack of a bowel movement for 3 or more consecutive days without mechanical obstruction, regardless of bowel sounds. Gastrointestinal intolerance in the ICU can result in increased time on mechanical ventilation, delayed time to obtaining nutritional goals, and prolonged ICU stay. Constipation may also contribute to agitation in some patients. While determining underlying factors causing the constipation, it is important to take the patient's past medical history into consideration. If a patient takes regular laxative medication prior to admission, it may be reasonable to restart the laxative regimen as long as it is clinically appropriate. If the patient is on opiate therapy, evaluate needs for ongoing opiate analgesia and other constipating drugs. If long-term opioid use is necessary, consider starting prophylactic laxative agents, especially if other risk factors are present. If the patient is dehydrated and or on diuretics, it is recommended to correct electrolyte and optimize fluid administration. When considering a pharmacological agent, there are oral laxatives and suppositories or enemas. Oral laxatives are broadly divided into 4 categories: osmotics, stool softeners, bulking agents, and stimulant laxatives. Oral laxatives are to be avoided in patients with an intestinal obstruction. Enemas are generally reserved for patients where the orally administered laxative did not have an effect and for patients with fecal impaction. Patients with raised intracranial pressure must not have drug therapies administered rectally due to the risk of further increases in intracranial pressure. Osmotic laxatives draw water into the lumen by osmosis and softens the stool. Saline laxatives may cause electrolyte disturbances and volume overload from absorption of sodium, magnesium, or phosphorus. Lactulose is perhaps the most widely used. However, it can result in production of intestinal gases with uncomfortable bloating in some patients. Since osmotic laxatives work by drawing fluid into the gastrointestinal tract and possibly decreasing intravascular volume, this can compromise hemodynamic status in patients who already have intravascular fluid depletion. Polyethylene glycol is also widely used and can be administered intermittently or continuously. Stool softeners like Docusate are unlikely to be effective in the critically ill patient, since gastrointestinal motility are often decreased in these patients. Stool softeners are mainly ineffective when administered without appropriate amounts of ingested fluids, which is often difficult to accomplish in the critically ill. Furthermore, when given alone to opioid-induced constipation, they are unlikely to be effective. Bulk laxatives are not ideal if a patient needs immediate relief from constipation. The use of fiber-based laxatives may result in fecal impaction without adequate fluid intake and may further complicate existing fecal impaction. Bulk laxatives should be avoided in patients who require fluid restriction, who are confined to bed, or who have strictures or partial obstructions. Stimulant laxatives work by increasing intestinal motility and secretions. Onset of action is typically within hours. As for patients on chronic opioid therapy, opioids alter neural input, inhibiting peristaltic contractions and propulsion, and increases fluid absorption, leading to symptoms of bowel dysfunction. Activation of opioid receptors, specifically the mu receptors within the GI tract, contributes to the pathophysiology of ileus after opioid use. Therefore, routine and scheduled use of stimulant laxatives are an effective treatment strategy for critically ill patients, since opioid-induced bowel dysfunction is common in the ICU. In severe cases of opioid-induced constipation, administration of neostigmine, an acetylcholinesterase inhibitor, may be considered to increase peristalsis and promote gut motility. Caution must be used in patients with severe cardiocirculatory problems because bradycardia and cardiac arrest has been reported with neostigmine use. The second option is methylnaltrexone, which is a peripherally acting mu-opioid receptor antagonist. It does not cross the blood-brain barrier and blocks opioid binding in the gut. Therefore, it increases GI motility without affecting analgesia. However, a low risk of opioid withdrawal still exists, so patients started on methylnaltrexone should be monitored for withdrawal symptoms, such as hyperhidrosis, rhinorrhea, anxiety, and chills. If opioid-induced constipation is suspected, recommend using a scheduled osmotic or stimulant laxative or combination of both for first-line treatment. Advise starting a bowel regimen if a patient will continue using an opioid regularly for more than a few days. If addition of the stimulant and osmotic laxative is not enough, may consider adding neostigmine to the bowel regimen or even switching to methylnaltrexone. I have included a table with the agents discussed in this presentation and available formulation options. Please pause the video now if you would like to refer to the table. Thank you for listening to my presentation. I would like to acknowledge the support received from my preceptor, Dr. Jared Butler. I have listed my contact information if you have any further questions. I will conclude my presentation with my 2 reference slides. Have a nice day.